So we've got Peter Orchard, who you can see here. He is the CEO of Canteen. Canteen is, of course, the not-for-profit organisation that provides free support for people aged 12 to 25 for people impacted by cancer. And Peter spent the last 30 years working with young people in a range of areas, including mental health. And a reminder that this is now your chance in the audience and also watching at home to submit your questions via Slido. And we'll put the questions, as many as you can, while we're live, but also we'll aim to get the questions asked afterwards. And we'll send those out later this week. And in this panel discussion, we're going to be talking about how a focus on priority populations and groups actually can improve outcomes for all people diagnosed with cancer. So let's start with Peter. Thank you for being here. So you've worked tirelessly to improve outcomes for and the lives of young people in Australia. What specific strategies are most effective to ensure that young people have equitable access to when it comes to age-appropriate cancer care and support?
Look, one of the things that we have running right now is the Youth Cancer Service Initiative, and it's an amazing partnership with the Australian Government and state governments. It means there are multidisciplinary treatment teams right across Australia working with over 3/4 of adolescent and young adult cancer patients. So that's a really important platform for identifying their medical needs, but also all of the other needs that happen around their cancer treatment and diagnosis, and come up with a comprehensive response to that. The thing, though, that is missing is that some of the wonderful things happening for paediatrics don't extend up to 25-year-olds, and so the upper age range is missing out. Really, 18 plus, even 16 plus in some states are missing out on this genomic profiling and treatment and targeted treatment.
So if you fall under that category, then you do have access, but if you're in that 16 to 25, you can end up missing out.
Absolutely.
And what about the geographical barriers as well for people and young people who might be outside the capital cities?
So you're right. The treatment for the types of cancers they have, because they are rare or rarer, which is why we work so closely with Richard and Kate and with the Rare Cancers organisation, it's the same challenge. And so the treatment for those rare or rarer cancers happens in a large metro treatment centre often, and so that means rural families, so about 30% of families live in rural and regional areas, would need to relocate to a metro setting for that treatment.
Okay, thank you, Peter. So I might go to Noel now. So thank you for your talk and your presentation. You said that when you were diagnosed with this rare cancer that it's a 1 in a million cancer, and it felt like for you being hit by a freight train with no signs of slowing down. And I would love you to share with the audience what information and support would have helped you and your family that you didn't get access to at the time.
So just more resources, because when I was in hospital and my surgical team told me about my diagnosis, they didn't really say much. They didn't really provide much information. Being told that it was cancer is overwhelming enough, and then let alone being told it's a rare cancer, and then asking, okay, so what kind of rare cancer is it? Just a lack of information, I suppose. And then when it comes to support, the only things or the resources that the hospital could provide to me at the time were, you could contact the council, we can organise a counsellor for you, Canteen as well. But yeah, Rare Cancers Australia was never offered to me or mentioned, which was surprising. Like I did not find out about Rare Cancers Australia until I was discharged, and I was already at home about maybe 8 weeks after, coming home from the hospital after my surgery, is when I found out about Rare Cancers Australia. So.
And what sort of a difference did it make when you were able to link up with Rare Cancers Australia?
They're one of my huge support networks, and they're incredible. And the fact that there's an organisation that exists specifically for rare cancers, like this is what needs to be the first critical or piece of information that is given to a patient when they're told that you've got a rare cancer, So So that patient can essentially make that contact with that organisation and get the resources and the help from the day dot right then and there.
So Michelle, I might just ask you, why do we need a different approach for kids and young people when it comes to cancer?
There's several reasons for that, actually. Firstly, childhood cancers are different from adult cancers. So children don't get the major types of common adult cancers. They don't get bowel cancer or breast cancer or prostate cancer or lung cancer. They get different types of cancers that appear to come from different causes. They're unlikely to be environmentally, not what you've eaten or what you've been exposed to, but they're coming from changes in the developing embryo where the cells that were meant to go on to form various tissues have actually had genetic changes that lead them down a path that will have them to cause cancer. In terms of the genetic drivers for adults versus children's cancers, there's about 50% in common, but about 50% of them are absolutely unique. And there's also the challenges that for children, because many of the standard treatments have attacked not just the cancer cells, but the normal growing cells in the child's body, because they're just designed to attack rapidly dividing cells. The challenges of late effects, side effects, survivorship for children with cancer are quite unique. And there's also the challenge that drug companies don't want to make drugs for children with cancer. So lots of reasons why it needs a separate research program.
I'll go to you next, Peter, but I just wanted to ask Michelle for you to just expand on what you alluded to in your presentation about that other countries around the world have legislation about drugs and cancer drugs and children. Can you explain to the audience what happens particularly in the US?
So in the US, there's a piece of legislation called the RACE Act for Children. So that stands for Research into Accelerating Cure and Equity for Children with Cancer. And what it requires is that it came into play in 2017, but it was fully implemented in 2020. And what it means is that any company that's developing a new drug that is capable of targeting a molecular target that has been identified in any type of child's cancer has to develop a pediatric development pathway, providing safety and efficacy data and collecting the data on children. There's similar legislation in Europe. In Australia, we don't have that. So we have a reliance on compassionate access to drug. It takes time, takes money. We have a huge dependence on off-label use. We can't get these drugs on PBS, the same sort of story, because even though it's the same target and the drug might work there, and we can show in the laboratory it can work, or there's evidence it can work, if it's not part of this framework. So all of this type of legislation can change that. Currently, there's a lag of several years between when a drug is available for adult usage on label to when it can be used on children. This framework is designed to change that, and it's been shown that only about 8% of these potential drugs where there is a common target with children before this legislation had a paediatric development path. Now fully half of them have got that, and there's been about 30 of these paediatric development plans filed since 2020 when this legislation came into action.
So Peter, you deal with, as CEO of Canteen, you're dealing with kids with cancer and their families, and what sort of difference would it make if we had a similar system like that in Australia?
It would make an enormous difference. Even some of the clinical trials that do exist now are not available to young people under the age of 18 because the pharmaceutical company doesn't want their product used on that younger age group because of the risks that might be involved to their company, even though in many cases it's unlikely that there are going to be any risks at all. Often paediatrics can cope with much harsher treatments really than AYAs. So that's a barrier, and so the sort of thing Michelle was talking about I think is critical, that we get drugs quickly and early that are offering opportunity and potential for treating the disease they face. The impact of just a single use cohort on the Australian economy. The lifetime impact is $1.3 billion. And so there are good economic arguments, let alone all of the compassionate reasons why we'd want to do that.
So do you think we're making, given what you see, Peter, with your people that you look after, are we making enough progress for children and young people affected by cancer?
No, not in this way. You know, as I talked about, in terms of genomic profiling, the upper end of the adolescent young adult age range doesn't have that access. We have it at the moment because Michelle receives funding from the Australian government, but that's got a lifespan at the moment. And
About 9 months.
yes.
9 months, okay. So I don't know if Mark Butler, he may have left, but if any of his representatives are in the room, we'll make sure that message gets out.
And so that's a really important initiative, but it's resting on time-fixed funding.
Yes, and it is limited based on age as well.
And it's limited based on age. And so I would love to see it refunded and for up to 25, that would really address that. And I think just then open up enormous insights into treatment, create potential new treatment opportunities and identify new targets as well.
Amazing. Let's turn to Indigenous health for a moment, and also don't forget, we do want your questions. I can see one come up already, but we're going to go to more. So Mike, there are some alarming statistics about Indigenous cancer rates. Between 2010 and 2019, the cancer death rate increased by 12%, while the death rate for non-Indigenous decreased. So that gap is widening. And we heard about the Australian Cancer Plan. What are your hopes for Indigenous communities in that plan? Does it really go far enough, do you think, to make a difference for populations that you are supporting?
Thanks. And again, acknowledging Louise's absence, I suppose it would have been great to hear her thoughts on that, and also to acknowledge my approach within this is more around access to treatments and not specifically on cancer. I guess, reflecting on the rare cancer submission to the Senate inquiry, as well as the recent announcement from the Minister, I actually think it was in 2023, investing in our sector, I think the really important things, and just also reflecting on the Moonshot document and some comments now, there's a central tension between accessibility quickly and doing things the right way. And there's a risk from our sector's perspective that equity can get worse because the way that a new technology is implemented isn't necessarily capturing the ways that our sector, for example, works.
Yes.
And so I think that's really an inherent tension that's very difficult to balance. And we saw with the aligned governance model, it's a big process to go through and get it right, to get all the states and territories involved, to get the right leaders. And a lot of these people, like Lorraine Anderson, who I mentioned, have got tens of committees that they need to work on. So to get the bandwidth to have the right people making decisions about implementation of these things is really difficult to do. And I don't think there's necessarily a silver bullet. One thing I will say is, though, I think this investment from government is towards support staff to work in roles, I suppose, like Noel would have accessed. They are Aboriginal and Torres Strait Islander people who are essentially care navigators for cancer. And so within a diagnosis, we know that a lot of cancer treatment goes through tertiary organisations. There's not necessarily a great vibe that Aboriginal and Torres Strait Islander people often get from going to hospital. And so this workforce, I think, is a critical enabler to help understand the new technologies, understand specialist services, to improve that equity. I think without them, there's a risk that new technology, genomics, will really favour people, as we've heard, in less remote areas. And there's certainly a lot of Aboriginal and Torres Strait Islander people who live in cities, hundreds and thousands, but there is also a skew towards regional and remote areas, so that in itself inherently biases, I suppose, these services.
Thank you, Mike. So one of the questions we wanted to ask the panel was, because given today we're talking about Moonshot, which is making substantial leap forward, and a question was, if the panellists had a magic wand, what would they change first for people with rare cancers? Noel, let's start with you. What would you change first if you had that magic wand?
Just have access to clinical trials more. Like there's two people that I know that have also got the same cancer as myself in 2 different states. One's in South Australia and one's in Queensland, and they're both on a clinical trial as we speak, which is a worldwide trial, but yet my oncologist has stated that there is no clinical trials for my cancer running at the moment for New South Wales. So yeah, that's something I wish I could jump on board right now.
Yeah, so more inclusive trials, so that where you were wouldn't necessarily matter, so you could potentially take part in that trial that the other people
Yeah,
are in.
100%. Yeah.
And what about for you, Michelle? What would you say are what's going to move things forward the most for people that you look after, for young people?
So it's having, I think for young people with cancer, and hopefully for slightly older young people with cancer, the answer lies in having sustainable, equitable access for comprehensive genomic profiling and for personalised treatment, working with government to actually transition that into the health system as standard of care, so that it's not ad hoc grant funding that comes in tranches and then everyone holds their breath to see what happens next, but to make this the standard of care for the young people. We've shown the benefit of precision medicine, we've shown the benefit of national access. Now we need a stable funding environment where we can harness all of the data from zero, have it as standard of care for every child, work with the Indigenous community, and we're actually just establishing an Indigenous working group and working with some of your people at TKI as well, specifically to do that, and to have more children, more young people to get these personalised treatments all the way through their cancer journey, harnessing these innovations that we've got, and ultimately understanding cancer risk better so that we can diagnose cancer earlier, manage it better, and ultimately prevent it.
Fantastic. And Peter, what about for you? Not only for the patients, but you also look after young people who have parents and family members with cancer as well. What would make a big difference for both those groups?
So a lot of their parents, might be experiencing common cancers, but many will be experiencing rare cancers. And so for those young people whose parents have been diagnosed, the thing they want is their parent there with them, traversing life with them. And so for their sake and for the sake of adolescent, young adult patients, the genomic profiling, the personalised medicine is really critical if we're going to move the dial on some of these rare and rarer cancers that have got very difficult survival rates. And so just critical for their sake. And I think the sort of spend in other ways of trying to get around that must be very high. If we have a just standardised approach, then I think that ultimately it will pay for itself.
So Mike, one question I wanted to ask you, we've got a very diverse audience today. We've got clinicians, researchers, patients, pharmaceutical companies, government, both in the room and watching online. What would you say to them about how best to engage meaningfully with this issue of inequity and engage with Aboriginal and Torres Strait Islander communities in a way that they can deliver better but also culturally appropriate care?
It's difficult. I mean, I think the difficulty comes in, I suppose, finding the right people to talk with, and our sector has to have lots of different priorities, and they're heterogeneous across different areas, and those priorities are really up to the autonomy of the organisations who are working with a specific community. So it would be hard to go into one community and inappropriate, really, I suppose, to transpose what you feel like the needs of the health needs are, for your organisation onto Aboriginal and Torres Strait Islander, a specific community. I think probably the most important thing is to listen and to have the environment where that listening can happen early. Because
is that why, the example you gave of that ear infection study, is that why you think that was potentially successful? Because it was very co-designed and
Yeah.
done for the community in consultation with the community.
Yeah, and you go back to data, which I think is just such a central part of this whole thing. A lot of our member services have relatively complex data infrastructure which they can understand things. I think maybe cancer less so, but I don't know so much about that. But those data then can really inform what are those priorities. And then those priorities are the thing that really need to drive what happens. So the way that some communities manage rare cancer may be completely different to others. So that listening is really important, and you can sometimes infer themes from literature, but ultimately it's listening to the communities on the ground, I think.
We might go to some audience questions now. We've got one saying, how can we ensure that clinicians and support teams can help patients find their people when there aren't major organisations for their rare cancer types? Who would like to? Maybe Peter?
Yep.
That might be something that people talk to you about.
Yeah. Look, we partnered with Red Kite and Camp Quality to create an entity called Cancer Hub, and really with a view of getting people to the supports they need. And so the idea is it is a bit of a one-stop shop where families with children 0 to 25 years dealing with a cancer diagnosis in the family can reach out and contact Cancer Hub and then have a navigator steer them to where they want to be or need to be. And so that would include, linking them into rare cancers. It would include linking them into Leukemia Foundation or other organisations. But it's just trying to make that more streamlined.
Because for some rare cancers, there's not going to be a specific organisation
Yes.
for that type of cancer, is there? So that would be a way that they can help navigate the system.
Absolutely. And and so that's part of the navigation work that Dorothy talked about in the Australian Cancer Plan, which is how that's been funded.
Interesting. And so don't forget, if you've got any other questions, keep them coming through Slido because they're going to pop up here and we can ask them. So Michelle, you talked about the legislation in the US and other countries. And that would be a way, obviously, that industry would then have to act. But are there other ways that we could incentivise industry, do you think, to develop more therapies for children and young people when the numbers really are so small?
Yeah, there are other mechanisms in the US as well where there's extensions to patent life on pharmaceuticals that are developed when there is a paediatric indication. So there are a number of ways, a number of options and opportunities in terms of incentivising pharma. We, through Prospect and working together where we now have the opportunity of bringing pharmaceutical companies into the country, there's the opportunity of saying, look, you have this world-class genomic sequencing that is being done through Zero, through Omico, as David has referred to it, from cradle to grave. And so this in itself gives the opportunity to demonstrate to pharma companies how they can actually expand their markets by coming to Australia as a one-stop shop. So this is a sort of a visionary new approach to how we can work more effectively with pharma. And we have developed model systems that they need to be able to test their drugs. So we can say we have unique data sets in this country. We will have thousands of these over the coming 4 or 5 years if we're enrolling 1,000 patients a year, where we've got the matched genomic data, the clinical outcome data, and the biological models. That's a resource that pharma companies need to help develop their drugs. So I think that we can help add value to them as well.
Fantastic. We've got a question that I'll go to Mike. The audience question is that we seem to be failing our kids, First Nations people, and rare cancer patients generally. And actually, we might ask all of the panellists, what's the one thing you would ask us all to do when we get back to our desks tomorrow? So what's the one action you would like the audience to take? What's the call to action to the audience, really?
Well, I reflect on the slide where we're all kind of players in this system, I suppose, and we all probably have some data or some influence over data. So I think probably even before that is, as I said, listening, reach out to an Aboriginal and Torres Strait Islander organisation that you may have an association with and ask to talk about what are the priorities for our sector, I suppose. And I think a lot of it's about networking and inferring needs. And then, there's all sorts of references that we've kind of built up, I suppose, but I think those personal connections are so important in our sector. There's one thing I would advise, I suppose, is to build relationships.
Fantastic. And Noel, what action would you like to see the audience take from what they've heard today that could, so they can step up and all become advocates for some of the issues that they've heard in this forum today?
Look, I'd probably my answer would be just to sort of tell your loved ones and your family to just get yourself checked out.
Take responsibility, look at your own health.
Yeah, like go get a blood test. Like my mum always told me every year, like, have you seen your doctor or have you had a blood test done? And I'm all right, mum. You know, I don't get sick, but then I'm a prime example. Like, for everyone that's known me, I've always been a guy that's into fitness. I've maintained my health, pretty well. And all of a sudden, blink of an eye, everything can change. So.
We've only got a couple of minutes left, so I want to go to each of our panellists quickly and just get them to answer this question very quickly about, in your view, what does a better world for rare look like? We'll start with Peter. What does it look like for you, for young people and their families?
Look, it's a much greater and consistent use of genomic profiling, and then all of the lab work that Michelle's talked about that creates then the opportunities for new treatments and new trials, and just really need to carry that forward. We've got some exciting stuff happening, but we need to carry it forward, and we need to open it up to 25 years.
Yes, so recognise that young doesn't necessarily end at 16. It goes, a bit longer than that. Michelle, just summing up briefly, what does a better world for rare look like from your perspective?
Yeah, I think the improvements in children's cancer survival rates over the years has been so dramatic that for many people children's cancer is seen as a solved problem. And I think that when you looked at the survival rates, isn't it wonderful? We've gone from 11% of these children surviving to 27% of these children still being alive 2 years later. Recognising that this is not a solved problem, recognising the enormous burden on families and the economic losses of loss of life. Young people's cancer is second only to breast cancer in terms of patient life lost. So for me, a better world is sustainable funding for precision medicine and for the research to continue to innovate that platform with those elements of it that should be standard of care in the health system, funded as part of the health system, and then funding to continue to do those innovations and those research developments. There is enormous opportunity, and I genuinely believe that one day this will be a solved problem. But ultimately, it does come down to money and expertise, and money brings expertise and grows it.
All right, thank you so much. And Noel, what about for you? What would you like to sum up for the audience? What does a better world for rare look like for you, in your view?
Just more time and money invested into research for rare cancers, and obviously more financial stability for rare cancer patients. I don't want someone that gets diagnosed with what I've been diagnosed with in the future to go through what I've gone through. So any sort of change there financially would be amazing. So.
And Mike, we'll just wrap up with you.
Sure. I think at the moment we don't know too much about it. So I think understanding what rare cancer looks like for Aboriginal and Torres Strait Islander people through data and that knowledge is essential, really ultimately to close the gap that we know exists at a general level in terms of cancer outcomes.